Hello, my name is Angela Eichelbosch, and I'm an Environmental Health and Knowledge Translation Scientist at the National Collaborating Center for Environmental Health. Today we're going to be talking about the opportunities for public health and the drinking water treatment industry to partner in reducing Canadians' lead exposure. This talk was previously presented at a Canadian Water Quality Association meeting in Kamloops on May 9th, 2017. The National Collaborating Center for Environmental Health, or NCCEH, is one of 6 national collaborating centers established by the Public Health Agency of Canada in 2005. We work at the national level to promote the use of knowledge and evidence by public health practitioners and policymakers in Canada. The NCCEH has a threefold mandate. We synthesize and exchange knowledge by incorporating evidence from both research and practice, and we provide that packaged information to policymakers. We also identify gaps in knowledge to identify important areas for new research, and we build capacity by providing tools, establishing networks, and fostering partnerships. Generally, we work with public health professionals like medical health officers, public health inspectors, and environmental health officers, but we also work with researchers and with industry. So today we're going to be talking about the Flint disaster. Flint is interesting both because of what happened in terms of the changes in water quality and chemistry, but also because of how it could have possibly happened, given the practices and regulations in place to protect the public from a mass poisoning event. We're going to be talking about that crisis today and what it means for the people of Flint. We're also going to be discussing whether it could happen in Canada. And finally, what role the water treatment industry can play in preventing it. The first thing we need to understand about Flint is that it was a slow-moving disaster that there were actually many opportunities to stop. Until recently, Flint had been receiving high-quality water from Lake Huron via the Detroit Water and Sewerage Department since about 1967. In 2000, that contract expired and the negotiations to renew failed. In 2011, the city went into financial receivership, and one of the state-appointed emergency managers decided that Flint should join another water distribution network. To cover any gap in service, it was decided that the city would reopen an old water treatment plant and, with minimal investment, use local water from the Flint River to provide the city. A feasibility study commissioned at the time indicated that the plant would need to use a corrosion inhibitor at a cost of about $100 a day. This advice was not followed, even though corrosion control was required for any system serving more than 50,000 people. On April 25, 2014, water from the DWSD was cut off and the Flint River water began to flow. Water quality complaints began shortly thereafter. From May to August 2014, there were complaints of smelly, turbid water and people getting rashes. There were multiple coliform violations and a boil water advisory was issued. But the emergency manager assured concerned citizens that the water was fine. There was also a spike in Legionella at this time that would eventually affect more than 80 people and kill 12. But the connection between that outbreak and the Flint River water was not recognized until much later. In October 2014, the General Motors plant reverted to Detroit water because the treated Flint water was 8 times more corrosive and was degrading auto parts. This photo shows 2 nails that had been left in water for 1 month. The one on top is Detroit water, and the one on the bottom is Flint water. In December 2014, the Michigan Department of Environmental Quality, or MDEQ, and the City of Flint carried out water quality monitoring. However, the samples were collected in a way that was likely to greatly underestimate levels. Furthermore, the MDEQ requested the city to drop some of the highest values out of the analysis such that the final result would fall below the U.S. action level of 15 parts per billion. The real average, with all values counted, was closer to 70 parts per billion. In January 2015, water quality testing found high trihalomethane, or THM, levels. The city then decided to use ferric chloride as a coagulant to eliminate that organic matter, causing the THM issue, instead of the more expensive alum option. The use of ferric chloride further increased corrosiveness of the water. In February 2015, Detroit offered to reconnect the city for free, and the mayor and council of the city voted to accept. However, then emergency manager Jerry Ambrose, who held decision-making power, decided not to revert. At the same time, the MDEQ and the EPA appear to have been discussing the lead showing up in people's water. EPA informed MDEQ that a corrosion inhibitor was necessary in their system, but MDEQ did not act, and the EPA did not enforce compliance. Also at the same time, a woman named Leanne Walters was conducting a citizen's investigation into the water quality issues, which she believed had been making her children sick for months. After city officials tested her water in February 2015, she contacted the EPA to voice her concerns. The EPA did not act overtly, but in July 2015, a memo was written by an EPA employee, Miguel del Toral, was leaked. That memo detailed all of the water treatment concerns with the Flint water so far, as well as attempted to understand what was happening in Leanne Walters' house. At this point, things began to happen. In August 2015, a Virginia Tech professor got into contact with Leanne and began a larger investigation of the Flint water, the results of which the city attempted to dismiss. Then, in September 2015, a pediatrician named Dr. Mona Hanna-Attisha came forward with data clearly showing that the blood lead levels of Flint children had increased relative to before the switch. Again, the city disputed her findings and accused her of fomenting hysteria. However, within a couple of weeks, the city recognized that the water was not safe, and on October 8, 2015, the city reverted to Detroit water. However, the damage was done at this point, as the protective scale in the city's distribution pipes had been removed, and the lead was still leaching. In January 2015, a state of emergency was declared, and FEMA stepped in. So Flint was truly a tragedy of errors and wrongdoing, and there were multiple factors at play here. Clearly, economic troubles were at the forefront of this disaster. The city was in financial receivership, and the state-appointed emergency managers had been given broad powers to cut costs, including trying to find cheaper water. However, a second layer to this story is that the city had been in trouble for a long time. Industry was leaving the city, the tax base was leaving, and as a result, the distribution systems that had been built to serve 200,000 people were currently serving only 100,000. That allowed water to stand on the pipes much longer and gave more time for those chemical processes to occur. The residents' time got even longer after the GM plant went back to Detroit water. Criminal negligence occurred in Flint at multiple levels. At last count, 13 people have been charged, including 2 state-appointed emergency managers, for shady financial management, 3 city officials, including the laboratory and water quality advisor, 3 MDEQ employees for misconduct and or tampering with evidence, and 3 people from the MDHHS, the Public Health Department, including their own director. The MDHHS is key here because it was their primary responsibility to investigate public health risks. But when water quality issues were raised, they simply accepted the claims of the MDEQ. In June, most recently, it was announced that several of the people already charged were also being charged with involuntary manslaughter of those people who died during the Legionnaire's disease outbreak. There was certainly a lack of oversight in this disaster. It was the EPA's job to enforce regulations as soon as they had an inkling of a problem, but instead, the information was not actioned for months. The EPA regional administrator resigned, and the EPA itself is being sued for nearly $230 million. Finally, many have questioned whether the same risks would have been taken in a town that was not predominantly poor and black. Certainly those social and health inequities made the situation worse once the disaster had occurred. The Michigan Civil Rights Union has a detailed document on the role of systemic racism in the crisis, and we're going to touch more on social and health inequities in this talk. In the emergency response, 9.3 million liters of water were distributed to Flint citizens. 50,000 filters and nearly 250,000 cartridges were distributed. They also expanded blood lead testing, Medicaid coverage, Head Start programs, and local health centers. $250 million was provided by the state, and $100 million from the feds for water infrastructure. In total, this disaster will cost potentially billions in infrastructure, treatment, lost income. And this is all in part for the lack of $74,340 or 531 days of corrosion inhibitor. So where are they at now? In January 2017, lead levels in Flint are back below federal limits, but citizens are still requiring the use of filters. Mark Edwards, the Virginia Tech professor who spearheaded some of the earlier investigations into the Flint water crisis, stated that there's no reason to believe the water in Flint is more dangerous than other U.S. cities. However, this is cold comfort given that lead is a prevalent problem throughout the U.S. So what will the Flint disaster mean for the individuals and communities affected? Most analyses stop short of addressing the public health consequences of Flint, and that's where we're going to dive into next. Because lead is a truly awful contaminant. It's one of the most acutely and chronically toxic substances that is also very common in our environment. That's why we think of lead as hideous and insidious. It's hideous because it is acutely toxic, it affects multiple body systems, and its effects are often irreversible. It's insidious because lead is commonly present in the environment. It has effects at low levels. Sometimes those effects are very hard to diagnose if you don't know what you're looking for, and the effects are, of course, worse in children. 10 micrograms per liter is currently deciliters, currently Canada's blood lead intervention level, meaning that that's the level at which public health policies or interventions should be triggered to reduce blood lead levels. However, there is no safe blood lead level. We know that lead still has serious neurological and behavioral effects at levels well below the intervention level. So at 10 micrograms per deciliter, neurological and behavioral effects can be observed. At greater than 10 micrograms per deciliter, an increase in spontaneous abortion, reduced birth weights, and premature births is observed. Above 40 micrograms per deciliter, anemia is observed, as well as reduced sperm counts. At above 60 micrograms per deciliter, kidney damage is observed, as well as reduced vitamin D levels. And finally, at greater than 70 micrograms per deciliter, patients may demonstrate encephalopathy, coma, and finally death. So where are Canadians currently in this scale? Based on the Canada Health Measure Survey dataset, the average Canadian blood lead level is about 1.2 micrograms per deciliter in adults and about half that in children. Only about 1% of people in Canada are currently above the cutoff of 10 micrograms per deciliter, which is down from 25% in the 1970s due to the effects of removing lead from gasoline and paint. So I've been talking a lot about guidelines in this presentation, and we should take a moment here to reflect on what guidelines mean. In the US and Canada, we have guidelines and/or regulations for lead found in drinking water, as well as intervention levels for lead found in humans. These are meant to be tools to help us prioritize who gets help first in a bad situation. They are not meant to be interpreted as a safe level for lead exposure. To date, best evidence indicates that there is no safe level of lead exposure. One of the critical problems in Flint is that the guidelines were massively misused. The State Environmental Agency, who should have known better, did not act on the rising lead levels, even though lead levels doubled from 6 parts per billion to 11 parts per billion over 6 months. Because the reading was still below the action level of 15 parts per billion, they did nothing. However, that doubling of lead levels in a short period should have set off alarm bells because lead guidelines are, in fact, a compromise between health evidence and what is reasonably achievable. They are not a threshold of safety. So public health has a problem in this respect because we need guidelines to target policies and interventions, but sometimes those guidelines are going to be misinterpreted. In the case of Flint, misuse or perhaps poor understanding of the lead guideline led to an additional 10 months of exposure that did not have to happen. Furthermore, there is more than one source of lead, and that cumulative exposure is critical. So where's all that lead coming from? Well, humans have been using lead for thousands of years. Famously, the Romans used lead in everything from face paint to wine storage. However, it really wasn't until the Industrial Revolution that we began mining and dispersing lead in our environment with a vengeance. It's estimated that humans have mined and released nearly 300 million tons of lead into the environment, mostly in the last 500 years. Atmospheric lead accounts for most of our exposure. It comes from leaded gasoline, which is still in use in some places, as well as ore processing, aviation fuel, and incinerators. From the atmosphere, that lead settles out into our soil, dust, food, and drinking water. Atmospheric lead also accounts for about 70% of exposure in children. In the home, lead can be found in dust from leaded paint in older homes, as well as pipes. Finally, some people are exposed through their jobs. We try to limit occupational exposure through the use of personal protective equipment, but exposure still does happen and can add to other sources. So what does lead exposure mean for individuals and communities? A great deal of research has looked into how lead in kids and young adults relates to their capacity and their performance in school and in life. Generally, these studies look at lead in blood, or occasionally fallen teeth in children and young adults. In terms of capacity, we find that kids that are exposed to even very low levels of lead have reduced intelligence, memory, attention span, language skills, reduced visual spatial skills, longer reaction times, and that their mood is negatively affected. In studies that look at performance, we find that kids exposed to lead grow into young adults who have lower test scores, lower class standings, lower vocabulary skills, and show an increase in reading disability, increased absences from school, increased delinquency, and even increases in arrests for violent crime. So lead exposure doesn't just affect one child for a limited period of time. It affects them through their entire development and in their interaction with society as a whole. This should not be interpreted to mean that every lead-exposed child is going to become a violent criminal. However, for every 10 microgram per deciliter increase in a child's blood lead level, it is believed that he or she may lose up to 4 to 7 IQ points. So what effect is that loss in capacity going to have on a child's ability to realize his or her potential? We know that IQ is directly associated with lifetime income. So what effect is lead exposure going to have on that child's earning potential? This is why we think that lead may actually help to perpetuate social and health inequities in our society. That is, if a child is born or moves into low-quality housing, they have a greater chance of being exposed to additional lead through pipes, paint, and dust. The smallest children are impacted the greatest, and that lead has irreversible neurological and behavioral consequences. Because they may perform poorly in school or have trouble coping with adversity and stress, without that behavioral capacity supported by good education, you have to ask whether that child is going to realize his or her full potential, or whether or not that potential has simply been reduced. If they then find themselves living and having children in poor quality housing, the cycle begins again. To repeat, this is not to say that lead exposure will turn every child into a violent offender. However, even if lead has small incremental effects on a child's ability to learn, to achieve educationally, and to earn higher incomes, families may look back over the decades and wonder why their kids had so many problems. Why was it so hard for them to get ahead? So a key question to consider is whether the Flint crisis could happen here in Canada. The answer is that we need to address our strengths and weaknesses. One of our big advantages is that most Canadians have very good source water quality. The Flint River water should never have been used as drinking water in the first place. We also have less aging infrastructure overall. The U.S. has perhaps 6.1 million full or partial lead service lines in places currently providing water to 15 to 22 million people as of 2016. That's down from 10 million in 1991, but still very high. Canada has an estimated 165,000 lead service lines, with about 35,000 in Toronto and 60,000 in Montreal. So the scale of our problem is smaller. Canadian institutions and networks are also very much into capacity building, and we are lucky to have that crosstalk between industry and public health. In Flint, the Health Department and the State Environmental Agency were collaborating, but not in a good way. We also have less social inequity. We do not have the same number of people experiencing the same severe degree of inequity as in the US, although we do certainly have communities and regions that are severely underserved. On that note, one of our primary weaknesses in Canada is that we are not addressing existing health inequities. The health gap between rich and poor Canadians is growing, and we do have many communities and regions that are severely underserved, that have many other health issues and many other drinking water issues besides lead. When we as a society don't address those inequities, we create a society that is less able to protect itself. We also have less stringent regulations. Although our maximum acceptable level is lower than the American level, it is a guideline only, and likely isn't low enough. Currently, Health Canada is considering lowering our lead guideline from 10 micrograms per liter to 5 micrograms per liter. Our ability for oversight in Canada is also much weaker. We have a smaller population to oversee, but they are also distributed over a large area, which is a challenge for public health. Water testing in Canada is patchy. It's very difficult to force people to test lead in their homes, but we could do much more with schools and other common spaces. In 2007, Ontario made it mandatory for older daycares and all schools to test their water. Here in BC, new requirements have also come into effect regarding lead testing in school. If you are interested in lead in schools, please check out our NCCH resource list entitled Lead in School Drinking Water, which is available on our website. Next, the lead service lines are still out there. As mentioned, we think that there are about 165,000 LSLs still existing, but that is just one estimate. And finally, blood lead monitoring. Ultimately, the Flint crisis was revealed by blood lead testing data after all other signals were ignored. This is important because in the US, blood lead screening is a routine practice for high-risk populations and for children insured by Medicare between 1 to 2 years of age. In Canada, we have certain local and regional biomonitoring or blood testing campaigns, but we are not surveilling or monitoring blood lead in a regular way. That said, even if blood lead testing is happening, it's important to emphasize that blood lead testing is not how we would like to detect a lead problem once the lead is already in humans and the damage is done. We really want to find those lead problems before they impact human health. So none of these weaknesses is critical except when they all align, as they did in Flint. So I would say that a Flint-type event is not impossible in Canada, but it is important to address our critical weaknesses. So we can help Canadian kids by understanding how drinking water treatment decisions are influenced. The health effects on families and children are ultimately the result of individual choices, mostly based on whether that person has the means and information to act. People are very influenced by social media and by what their friends and families are doing. Once you can influence that immediate circle of friends and family, you have a pretty good chance at changing behavior. Both local public health and drinking water treatment professionals are trying to access that influence space. And although our interests are slightly different, we both have a common interest in promoting public health, and we have a common understanding of water quality through our national and provincial guidelines and regulations. What I think we often forget is that all of this decision-making is happening against a background of social and health inequity. As we talked about before, a person may have heard about lead on Facebook through their doctor or even from the contractor who came to do some lead testing. But even having heard that, they may be less informed about lead health effects. They may be short on cash, or they may just have too much going on to act. All of this makes it extremely difficult to get a message through. Public health tries to influence people two ways, through physicians and through information campaigns. Communicating through physicians is generally effective, whereas information campaigns are fairly ineffective when it comes to lead in drinking water and many other health hazards such as radon or asbestos. This is because although people may read our health information, it raises other questions like, how difficult is this to fix? Or how much is this going to cost me? And because there is no personal contact, it's very difficult to get those questions answered satisfactorily while the person is still motivated to act. If a person waits too long to figure it out and get all those answers, the urgency or motivation dies, and they are less likely to act at all. Regarding those social and health inequities, people with low socioeconomic status are less likely to have access to information, are less likely to perceive it to be risky even if they do, and are less likely overall to act. Other stressors may also come into play. I have been talking about lead like it's the only thing going on, but in fact lead effects are impacting low-income kids along with many other stressors such as air pollution, noise, secondhand smoke, inadequate housing, malnutrition, and lack of play space. So drinking water treatment professionals have a big role to play here. First of all, drinking water treatment professionals are very much trusted by the public. Research has shown that people view the drinking water professionals as a very reliable source of information. This may be because expertise proves itself, as in you wouldn't be in business very long if you weren't good at it. You also share technical knowledge, which is more relatable than some of the information public health uses. You have greater personal contact with people, and you have two-way conversation about what the problem is and how to address it. Because drinking water treatment professionals are often on site, they are able to assess other issues that may be impacting the problem. You're focused on individual benefit rather than general population benefit. And finally, you're viewed as problem solvers. So public health and the drinking water treatment industry are clearly partners in public health. But we don't often work together that much, and sometimes it isn't clear what we do and what we don't do. The primary functions of your local public health authority or health region are to inspect and advise facilities, to enforce regulations, to do limited health surveillance depending on where you are. Not every health authority has the ability to do this, to assist in setting or informing guidelines, and to develop and implement policy interventions, such as blood lead monitoring where necessary. So how can we help each other? Based on our skill sets, I think we have something very valuable to offer each other. Public health people spend a great deal of time doing risk communication, which is the fine art of providing just the right amount of information to motivate action without causing a panic. We also do exposure assessment and hazard assessment to come up with a fair picture of risk. A big part of that is collecting the right information at the right time from the right people or houses. Public health also stands to gain a lot from your collaboration through your connection to the public, through the opportunity for good risk communication, and through collaboration with public health on identifying those policy versus practice gaps. So what can you do when you encounter clients with high lead levels in your business or practice? First and foremost, be ready with the facts, and I hope that today's information has been somewhat useful to you. There are also fact sheets available from most health authorities, and it is immensely helpful to keep some printouts of those 2-pagers in your truck or in your office so that you are ready when someone asks for information. Another thing you can do is help your clients to prioritize risk appropriately. For example, I know that a lot of people out there are very concerned about fluoride in their water and may want to spend money on getting rid of it. However, although fluoride can have negative health effects, we only see those effects at levels much, much higher than are typically found in Canada. Therefore, if you have a client asking for advice on fluoride, but you know that they have lead pipes in the house, or arsenic in their well water, as another example, encourage them to address those very serious health concerns first. One thing that you can say safely to all of your clients is that they should reduce lead exposure wherever possible, and not just in their drinking water. It's also a good idea to identify your partners in public health and get them involved where appropriate. Use those guidelines cautiously and take a lesson from Flint. If you see a large water quality change in something dangerous like lead, think about what it might mean, even if the level is still below the maximum acceptable concentration. And finally, be aware of those local lead abatement programs. Members of the public may not be aware of opportunities within their own communities. So that's all we have for today. I want to thank all of you for taking the time to listen to this talk. We want to recognize the contribution of Mr. Nelson Falk, who developed an earlier version of this Flint case study. We hope that you've come to a new understanding of how public health and drinking water professionals can come together to protect Canadians' health. Please also check out our other resources on our YouTube channel and on our website at www.ncceh.ca. You can also interact with us through Twitter, Facebook, and LinkedIn. Have a great day.